right, so I think we're pretty close to 9:35. I'd love to introduce all of the people in the audience, and I think as we get to the Q&A section, we can do that if we have time. But I think, in interest of time, I'll start right now, and I'll just give you like let me just share screen. All right, so I'll just quickly give you sort of like an overview of what this is. Really, like, the goal is to just bring people from different communities together and have a place to learn and explore and just like chill and talk, because part of this is what makes life vibrant and beautiful. And what's really interesting and precious about our group is that we've got clinicians, we've got researchers, we've got high school students, we've got undergrad, grad, and we have people completely outside of academia and medicine. And just as a quick overview, we'll have 4 talks, and the talks will be like 7 to 10 minutes long, but I won't stop the speakers. So if they go over, it's really not a big deal. This is like a chill, informal sort of event. And so, Dr. Lora Kahn will talk about surgery for epilepsy. Dr. Korak Sarkar will talk about advanced visualization in neurological diseases. Dr. Abhijit Bakshi will talk about human postural balancing, and I'll talk about balance and stabilization in sort of like a spaceflight analog condition. So the first goal is just to be able to like explore these topics, learn about them. What you'll also notice is that these topics are not actually grouped together thematically, which is kind of cool, because what that means is our second goal is, after the presentations, just based on how much time we have, through question and answer, actually brainstorm what could the commonalities and collaborative threads be in these presentations that maybe don't have like an obvious thematic glue. And I think that's sort of like an exciting puzzle, and that gives us a way to explore multidisciplinary ideas. And that's really kind of the stuff that excites me. I'll try to hold the questions all the way till the end, so that the questions that are being asked hopefully are asking things that connect different presentations together. And I'll also record this, because this is part of like educational outreach, and I want to make this available to the larger public so that they can just absorb the coolness. Okay, so without any further ado, I'll sort of like introduce the really awesome speakers. And the first speaker will be Dr. Lora Kahn, who's a fellowship-trained stereotactic and functional neurosurgeon, and was inspired to become a neurosurgeon while studying cognitive neuroscience and psychiatric disease under Nobel Laureate Dr. Kandel. During residency, she developed special interest in deep brain stimulation therapy for Parkinson's disease, essential tremor, dystonia, and obsessive-compulsive disorder, together with surgical treatments for epilepsy. Her research interests include optimization of imaging studies in minimally invasive epilepsy surgeries and safe application of neuromodulation for treatment of debilitating psychiatric diseases. And she'll talk about surgery for epilepsy. And thanks so much, Laura. This is like such a treat and honor. I'll stop sharing, and then maybe you can start sharing.
Well, thank you so much for inviting me to this salon of neuroscience. And I'm excited because there are a lot of things that I haven't thought about in a number of years that inspired me to this work in the first place, including actually my honors thesis in college was about the intersection between art and neurobiology. So a discussion for another time. So I wanted to talk a little bit about epilepsy surgery today, because this is a really exciting field that's integrating a lot of different interesting aspects of neuroscience. And I'll start very basically, because I know that not all of you may even know what epilepsy is. So epilepsy is just an abnormal firing of neurons that doesn't serve a purpose. So normally neurons fire because we're like, hey, I want to lift up my right hand. And so the neurons come together to send a signal that's useful. Epilepsy is when neurons start firing together in a way that's not useful. And it can lead to things like people falling to the ground, or it may manifest more simply, just someone staring off into space for a while. But there's a whole range of that. And just discussing the way that that can be expressed would be a whole 10-minute topic of its own. But at any rate, the idea of doing surgery for epilepsy is nothing new. We know that since 3000 BC, people have actually been surviving surgery for this indication. And we know that because skulls that were found from that era show evidence of remodeling after holes were made in them. It's a surgery called trephination. It wasn't until, at least in Western culture in the mid-19th century, that doctors started to understand that it was actually a cortical, meaning part of the brain itself, rather than a skull-based disorder. And that's when surgeries started shifting into the brain. So just some more background, about 3 million adults in the US have active epilepsy. That's over 1% of the population. And about 40% of those patients have drug-resistant epilepsy, meaning that medications that are designed to treat epilepsy don't adequately control their seizures. However, less than 1% of appropriate candidates are actually referred for evaluation for seizure surgery because of a number of factors that I'll discuss shortly. The reason that this is a really big deal is that epilepsy isn't just disabling because of the seizures. There's a really high rate of what's called sudden unexplained death in epilepsy, meaning that patients can die for reasons that are sort of unclear when they have poorly controlled epilepsy. So this is a real consideration in people's lives. So why aren't more patients referred for surgery? Well, a lot of people who would send them in the first place are kind of scared, like your primary care doctors, general practice doctors, or even neurologists in the community don't have a lot of awareness, which is why I'm excited to talk to you all about these opportunities today, because even if you guys don't go on to become neurologists, since you're all people who are interested in the sciences, you can help spread awareness of this and some of the really cool things that are being developed. And maybe you'll have some great ideas of how we can do this better than we're even doing it at this point in time. A lot of patients and families are scared, and there's a concern about cost, but it's actually cheaper to do surgery than to have continued lifetime seizures. So who's a candidate for surgery? Anyone who's failed 2 medicines for surgery at a normal dose. Doesn't count if you're like not taking your medicine, but any patient who's taking it and continues to have seizures despite that. And then there are some other things that kind of help us to predict who's likely to be a good candidate and who's not. Now, if you're interested in looking in the literature at seizure surgery success rates, you have to understand the Ingalls score. So this is how we score how successful a surgery is in stopping seizures. And so the best is an Ingalls 1 outcome, and that means that the patient is free of all seizures. What's interesting here is that you'll see that we're talking about time of 2 years. So you can't give an initial Ingalls outcome until you're actually 1 year after surgery. So that gives you an idea of how we're talking about longer term solutions for people's lives here. So in the last 7 years, I would say the way we approach epilepsy surgery has been completely revolutionized. And that's because we now have a lot of minimally invasive technologies. It's an interesting theme that you'll see, I'm sure, throughout your academic lifetime, is that as general technology improves, so too does medical technology. And the two feed each other hand in hand, because many, many research dollars, as you guys can understand, come from the biomedical sciences. And ultimately, the reason that we invest so much, government funds, private funds, et cetera, is because obviously all of us want to have better quality of life and save those with rare diseases, et cetera, et cetera. I would say epilepsy is not a rare disease, but certainly one of the more disabling ones. But in the last few years, because of the advent of improved technology, we're now able to break things down into sort of 2 groups within seizures. So there are seizures that we can localize, or we can figure out where the initial onset zone is that excites the cells and causes that abnormal firing that I already described and causes the downstream manifestations, versus those that may have multiple areas in the brain that start the seizures, or where we can't easily identify where the seizure onset zone is. So when I'm explaining this to my patients, I'll say, hey, we can get an idea of where the neighborhood is, and we have to be able to find a specific street within the neighborhood in order to offer you certain surgical treatment options. In other cases, when we can't do that, or the patient is unwilling or unable to go through a localization procedure, then we have some other options, which I'll briefly discuss as well. But the first step for us most of the time in seizure surgery is figuring out where the seizures begin. And so there are a number of tests that we can do. I'll spare you the details of these to figure out, before we even go to surgery, what the neighborhoods of interest are. And this includes, doing scalp, EEG, and various imaging tests. And then what we actually do is use a robot to insert multiple probes into the brain, as you can see here on an X-ray. And this is a picture of what they kind of look like in real life. This is the scalp here with the haircut. And then this is what it looks like if you're looking frontwards, like this direction through the brain. And so what these allow us to do is map in 3D space the neighborhoods of interest and figure out where specifically the seizure onset zone or zones may be located. And we use a robot because in the past this was done with a head frame, which is still used to some degree in neurosurgery for very, very precise placement of things. But the robot makes it a lot faster and helps to minimize the use of human error. Now, the robot doesn't do the work for me. I wish I could just like sit up in my office and watch it operate for me. It doesn't work that way. It's just a trajectory guide, and it gives me a guide for my drill to go through as I place these to make sure that I'm avoiding dangerous things in the brain, like blood vessels. Then once we have the EEG data, and this is kind of what a raw EEG looks like in these cases, we actually have software now that allow us to analyze and say, hey, where the red dots are, that's where the seizures are beginning. So those are the areas where we'd be interested in going in and doing something to disrupt the seizure network. So the most traditional surgery for this is an open surgery called a temporal lobectomy. That's a fancy way of saying that we go in and we take out the part of the brain that's green in this picture. And that's done through a craniotomy, which is a temporary opening of bone window in the skull so that we can access the brain directly and take out that tissue. Now, we have a lot of years of experience of doing this particular type of surgery, and this is sort of the original way that seizures were treated if the seizure type made sense to be coming from this part of the brain, just based on how a patient would actually have their seizures. Something that also became even more popular once we started getting MRI imaging, which really isn't that old. I know that most of you are pretty young, but for some of us, MRI on this call, so MRI was actually developed during our lifetimes. So that would allow us to see that, you know, one part of the temporal lobe, a region of the brain, looked different than another. Now, this is a really successful procedure for the appropriate patients, but there are some, you know, there's a lot of pain involved. And as you can see, we remove a lot of brain. This is the part that's missing here. This is the part that's missing here. And this is the part that's missing on this view. And so that can lead to complications because the more brain we remove, the more disruptive it is for the body. So we've come up with a minimally invasive alternative. Basically, what we do is we use a laser catheter to be placed again with the robot in a very specific area to be able to cook that tissue and break up the seizure network that way rather than having to open things up and remove it. So we can use this as a tool. It's just like a knife. It can be used for any region, but it's been mostly used for this so far, but now we're starting to use this too for things like deep-seated brain tumors or radiation necrosis after someone has had radiation for a brain tumor. Necrosis means dead cells, things like that. So any place that there's a deep-seated thing that's just hard to get through without having to go through a lot of other brain, this can potentially be used to cook the tissue. I tell patients it's like being microwaved. Now, what are the success rates of this versus the traditional surgery? Well, we've started, now that we have more experience with it, to understand that if we're more central, or what we call medial in the brain, we're more likely to have good outcomes. Whereas if we're a little bit further back or to the side, we're less likely to have those good seizure-free outcomes with this technique. So this is an interesting application when you think about looking at computer learning and things like that. How can we come up with the best designed computer learning algorithm to get this part versus this part? And it becomes more difficult to plan than you might think, because when we're planning these trajectories, first of all, it's a straight piece that has to go into a curved structure. And secondly, we have to avoid all the dangerous blood vessels and fluid spaces and things like that on the pathway to get there. So right now, our experience is that the seizure freedom rate with this technology is just a little bit lower using the laser than with the open surgery, but the side effects are a lot less. So most patients choose that if they're a candidate for it. Now, the next question becomes, what if the seizure onset zone is in the part of the brain that lets you move your right hand? Well, obviously you don't want to like remove that tissue or permanently burn it, because that's like creating a stroke in the area. So what else can we do? Well, we can provide electrical stimulation or neuromodulation to temporarily stop those neurons from getting excited and firing and exciting other neurons around them and making a seizure that's going to spread through the brain. And so there's now technology called the responsive neurostimulator that lets us put electrodes right in the areas of seizure onset. They connect to a battery that actually sits in the skull and will record seizures in addition to providing electrical stimulation to help break them up. And so this is what it looks like in real life. You can see the battery, and this is someone's skull, and this is where the leads are going into their brain. And this is what it looks like on X-ray. And then patients actually download their seizure data onto a laptop about once a week so that the seizure doctors can look at it and make changes if they need to. The seizure freedom rate with this isn't as good because we're not able to stop the networks as effectively as if we remove the tissue, but it's a great option for patients who otherwise would not be surgical candidates. There are a number of bigger surgeries that we do in kids, but in the interest of time, I'm going to skip over that for now. And what do we do if we can't figure out where the seizures are beginning in the brain? Well, we can break up general seizure propagation circuits. And so we can put a device in the neck on a nerve called the vagus nerve. And that will actually send upstream effects into the brain and help break up seizure circuits that way. And this is what it looks like in real life. So this is the vagus nerve, and it's under a lot of magnification here. It sits in the neck between the two big blood vessels that carry blood to and from your brain, the carotid and the jugular. And so it's three little loops that actually sit around this device, around the nerve, and provide electrical stimulation. And we know that this device can actually really reduce the rate of sudden unexplained death in epilepsy that I mentioned at the beginning of the talk. What's also interesting is that we know it increases serotonin and norepinephrine release in the brain. So this is really helpful for moods as well. So it's actually FDA approved for treatment of depression. But because the institute in the United States decides what insurance will pay for and what it won't, hasn't approved it, it's not something that's used as widely as it might be. And so there's actually a trial going on now to see whether we can get CMS to pay for this as an alternative for patients who don't respond well to medical treatment for depression. And then finally, deep brain stimulation is another way of providing electrical stimulation to the brain that's been popularized for movement disorders, things like Parkinson's disease or essential tremor, where people have shakes that they can't control. And so we know that we can basically interrupt the movement circuits by providing electrical stimulation. So this has been used for years and years and years. It was actually developed in the 70s with people tinkering in their basements and garages with technology that had been developed for pain in the spine. And they applied it to the brain instead to help treat a number of different issues. And so it was just FDA approved in 2018 for treatment of epilepsy in a different part of the brain than we use for movement disorders. So again, this one we can do without knowing where exactly in the brain the seizures begin. So there are a lot of exciting areas for research in this. I like to tell people I have the coolest job in the world. I get to make people's lives better every day using lasers and robots. So it's pretty next level sci-fi nerd stuff. But there's still a lot of room for improvement in this field. And so that's where you guys come in. So we need to do head-to-head trials looking at the different neuromodulatory technologies. It makes intuitive sense to us that being able to put electrical stimulation right where the seizure begins, instead of breaking up a general seizure propagation circuit, would be more effective for stopping seizures, but no one's ever actually looked head-to-head to see which one works better. We're looking at creating longer battery lives, so patients have to undergo fewer surgeries, looking at biomarkers, things, in other words, like the VNS will sense if a patient has a rapid change in heart rate, because we know that a change in heart rate can be associated with seizure onset. And if so, the device will fire and help to break up the seizure circuit. We're constantly introducing new ways of changing the brain tissue to help break up seizure circuits. And we're always looking into improved imaging technologies. Finally, brain-computer interface is a really interesting developing field now. And I'm sure you guys have seen some of the papers that have come out on that, even in the last few weeks, like in New England Journal and so forth. So I just want the takeaway point from all of this is that this is a really exciting field that's growing rapidly, the field of stereotactic and functional neurosurgery. And I think all of you can make important contributions during your lifetime to this field to help make people's lives better. It's something that's underutilized right now. And so take this away. And if you think of patients in the future or can help educate others about these opportunities, that would be wonderful.
Thanks so much. Oh, sorry.
Stop my share.
Yeah, thank you so much. It's so fascinating, so interesting. And I definitely will have questions at the absolute end. And so now I will introduce the next speaker, Dr. Korek Sarkar, and he is a board-certified neurologist who completed subspecialty training at Northwestern and Shirley Ability Institute in brain injury medicine. He has served as an innovation fellow at Northwestern Center for Device Development, and he has been very active in research throughout his career and was awarded the American Academy of Neurology's Founders Award in Translational Research. He participates in the AAN's policy and advocacy efforts and serves as a member of its health policy subcommittee. He's currently an attending physician in the Department of Neurology at Oceaner Health and a staff physician in the Department of PM&R in New Orleans Veterans Affairs Medical Center. He serves as a clinical liaison for innovation, Oceaner, as well as the director of Oceaner's Neuroscience Medical 3D Lab, which applies advanced manufacturing, virtual and augmented reality to healthcare delivery. And he'll be talking about advanced visualization in neurological diseases. All right, so Korek, feel free to start sharing your screen.
First, thank you for that warm welcome and arranging all this. It's exciting. Like you said, this is the spice of life. And Laura, that was really just inspiring. There's a lot of students on this call, and I'm quickly realizing and reflecting that I'm entering the middle of my career. And a lot of those things that you just spoke about, I remember in training in medical school and as an undergrad, being like, that's the future. We're going to be doing deep brain stimulation, and that's what functional neurosurgery is going to be. And to be able to see it and work with someone that's actually bringing that to bear is really cool. So I don't know if I'm going to be able to live up to that, but I will be talking about 3D printing in XR in healthcare. So I do actually have a disclosure. This is relatively recent, but I served as a Doximity fellow. It's not relevant to this talk. And I don't have them in the core slide set, but there may be some intraoperative imaging. And so I'll give you a heads up just in case that's not something you necessarily want to see at 9 o'clock in the morning. So what inspired me to go down this path was about 10 years ago when I was at the end of my training and looking at an image like this, which is a CT scan, and even in a room full of mostly neuroscientists, this isn't really clear what this is. And even in the hands of an expert, the pathology here, the specific 3D anatomy of that pathology may not also be clear, even to someone that's been looking at these for 10, 20, or 30 years. And so this was around 2012, 2013, around the time 3D printing was being introduced to the masses. It had been around for some time, but sort of the purview of, the Brandeis universities and the NASA's, not the tinker in their garage. And that was shifting. And with a little bit of like millennial gusto, I was like, I'll just YouTube and figure out how I can change this medical imaging into something that could be 3D printed. And it turned out to be a little bit more of a challenge than I expected. But for a couple of just level settings. So what exactly is 3D printing? It's also known as additive manufacturing, which is in contrast to subtractive manufacturing. In subtractive manufacturing, the prototypical example is sculpture. You have a piece of stone, you chip away, creating negative space, and out emerges the eternal springtime. The additive correlate would be you scan the eternal springtime, and then using a variety of methods and materials, you lay one layer on top of another to create a three-dimensional object. I learned in this journey, there's actually a really relevant complementary adjacency to additive manufacturing in mixed reality, which has a variety of terms of spatial computing, immersive technologies, but in general, they encompass two broad categories: virtual and augmented reality. And VR is complete immersion in a digital universe, whereas augmented reality is more along the lines of Pokemon Go, a digital model superimposed on the real world. And so, fast forward almost 10 years, this is what we do. This is our bread and butter right down here at Ochsner, and specifically with the neurosciences, where we, with people like Dr. Kahn, have really operationalized this. So the clinicians order imaging, usually CT or MR. You get them in the traditional presentation, and they're stored in something called a DICOM, a digital imaging communication and medicine file type. It's like a JPEG or an AVI or a GIF. It's just a file type that in general medical imaging is stored as. And taking that data and converting into something that can be visualized in 3D is called segmentation. And initially it was just transforming into something called an STL that could be fed into a 3D printer. As we've grown and expanded and included different modalities, there's a lot of different kinds of 3D files that we are converting DICOM data into, including for VR, augmented reality, and holographic display. And so why do we do this? You see the scan again on the left. If I told you, gave you a little bit of a reference, oh, that's someone's neck, most of you would be like, man, that is not right. That is not bending in the right way. You don't have to be a neurologist or a neurosurgeon or a spine surgeon to realize that. But on the other end of the spectrum, again, even in the hands of an expert, a colleague of ours, Dr. Kalivis, trained in one of the best neurosurgical hospitals in the world, is specialized in spine. The specific anatomy of in visualization is not trivial. And there was a couple of complicated things about this individual. Cervical deformities are in general more complicated. And as you can see, this individual had a lot of asymmetry in their shoulder, and you probably appreciate some of the lesions that she has on her skin. And so she has a disease process called neurofibromatosis, and our skin and our nervous system in the early days actually come from the same progenitor cells. And so these lesions were also present throughout her nervous system and her spine, and she'd actually had previous spine surgery. And it may be hard to decipher, let me see, but if you look on the upper right panel, in the back view, looking from behind, there should be two actually arteries called the vertebral artery that feeds the back of the brain, the vital, all of it's vital, but the, what I refer to as a lizard brain, heart rate, a consciousness at a primal level. And so even more risky because now she only has one of those. And if anything were to happen to that, there would be a lot, high risk of mortality and morbidity. And you can see here that she did pretty well. And not just in a picture, clinically, she has done tremendously. This is some of the work that we've been doing with Dr. Kahn. And this is more of an academic group, and I consider myself more of an academic, but operationalizing something in the real world, it's definitely necessary to have that academic background, but it's not necessarily sufficient to scaling. And what is probably necessary and sufficient is the rigor of academia, the scientific method, as well as a sustainability model. And that was a question after I, initially even figured out how to do this. The questions came early and rapidly, like, why? What's the point? Why are we spending time and money trying to do this? Why am I going to, why shouldn't you just be seeing patients? And a good question that is not completely answered, to be honest. But this is a use case that obviously has a clinical impact in working up individuals for epilepsy surgery, like the ones Dr. Kahn does. And this was a program we were trying to build. There was a software that was basically doing segmentation that was procured, was being underutilized, if not utilized at all, basically, because no one had the time or expertise to really actualize it. There's things in medicine, I'm a health policy wannabe nerd, but I'll spare you a lot of that unless you're interested. But the way medicine works, the economics makes no sense. But you figure it out, but there's billable codes. And so there was a billable code for what we're doing here. And then what resonates really most for me is looking at the number of patients we were able to evaluate as a team. And it went from 28 in 2019 to 59 in 2020, which sounds like, oh man, that's double. But also contextualized, 2020 was the pandemic, and almost all elective procedures were at some point shut down. And this is also an ethical question. What is an elective procedure? If you're someone that has refractory epilepsy, you may not think this is an elective procedure, but others may say this is an elective procedure. So not the full year was, that 59 patients isn't the full year even. And that resulted in a substantial increase in revenue, which, is important. Whatever we would think about it or not, that's what allows programs to grow funding. And so, I have a couple of more slides just to broaden the conversation, but when I started down this road, if you were someone that was interested in neurosciences or healthcare, and you were talking about 3D printing and mixed reality, people would look at you pretty funny. I know this from my experience. But you fast forward, and these fields are rapidly converging. And I'm really privileged and proud to work with people like Dr. Kahn and others at Ochsner that we're pioneering it in a way that I think a lot of people wouldn't have expected. And so what's the bold, audacious goal? Right now, we're using these modalities for anatomical modeling, patient education, medical education, procedural planning, and procedural training. The aspirational goal is to move these tools and capabilities to create patient-specific instrumentation and implants. Not Stryker implant 10, this is going to be grandma's spine, or this is the exact epilepsy grid we need for this individual to monitor, and then using advanced manufacturing to create that, and then using mixed reality, augmented reality to deploy and execute. And 18 months ago, even for me, that seemed a bridge too far, but then something happened that necessity is the mother of invention, and we've all been affected by the pandemic. And then now more than a year ago, it seems like a lifetime ago, New Orleans was early and unfortunately hit very hard. The fog of war was really dense. No one really knew. Like a year and a half later, we sort of understand to a degree, although recent news is also disconcerting. But I think we have an idea of what COVID is. March of 2020, we did not. And there was lots of questions and lots of issues and barriers. And one of them was the disruption of the health supply chains in general, but healthcare supply chains, and then specifically PPE. And so not by design, but the team's capabilities and the tools we had, we were able to pivot and start creating locally with our ecosystem, personal protective equipment. And, it's one thing to 3D print 10 face shields. It's another to mass produce tens of thousands of face shields, logistics, storage, sanitation. And, first and foremost, we didn't want to put anyone in more harm, particularly patients and clinicians. So how do we assure that? And, creating unique, what would have been edge cases in 2018 became problems because, like, of hearing is visual. We are all leaders, and all of a sudden everyone is wearing a mask. So if you were hearing impaired, or you were just born and you're in the NICU and you can't see your mother's face, that's an issue that wasn't ever even on anyone's radar 18 months ago. And so understanding, vetting, and designing solutions and scaling and executing them became something we as a system and as a community became very effective at. And I'm going to throw this in. There's a couple of people on the call. I think this is something we can talk about more. So we also use XR for distraction therapy as a therapeutic. We've done a couple of studies, most significantly in orthopedics, for cast removal hardware manipulation in kids. And so we developed internally with our developer a rock skipping app, and then we deployed this. And what we found was there was subjective improvement in anxiety in these children, as well as more of a biological surrogate, less heart rate variability, which it's a coarse but growingly reliable physiological and objective metric of a variety of things, including anxiety. And to this group, something maybe we can discuss is what I refer to as the neurophysics of XR healthcare. It would be great to throw on a VR ocular training or concussion rehabilitation application, but this person also has vertigo. And I mean, I love VR, but I can only stay in VR for 15 minutes before it becomes, and that depends on, if it's a race car game. Like I think a friend of mine's on this, Mike, and he threw me in a race car VR game, and I was hungover for a day after that, and I hadn't drank a thing. So it's going to be a barrier, and as well as an opportunity for scaling therapeutics using non-conventional modalities. So a couple of things that hopefully we can talk about. Segmentation is that process of converting medical imaging into 3D files, and that's growingly a rate limiting step. And how do we increase that capacity? There's human resources. How do we augment that? And the term du jour that in this room particularly, I won't tread too deeply, but machine learning, is there a role there? I know there's people way smarter than me on this call that know about that topic. Talked a little bit about the neurophysics of therapeutic XR. And then stepping back in general, again, it's a privilege to be included in this group. It's exciting, and it's inspiring. And there's a particular zeitgeist now in healthcare for what I call non-clinical technical talent, non-traditional people that have very important core competencies that traditionally haven't been deployed in healthcare. That there's an important need in the future, biomedical engineers, machine learning folks, materials, mechanicals engineers, basic neuroscientists, all across the board. There's a need, and there's a moment here to create a more sustainable and equitable healthcare delivery system. And the current model is not that. So I look forward to the discussion. And again, thank you for the opportunity, and I'll stop sharing.
Thanks so much. And I think Lora has like an additional component to put on. So Lora, yeah, I'm interested to see what you're going to add on. And then we'll go to Avi afterwards.
I just wanted to show how Dr. Sarkar's work can be applied in real time to a case of mine. So I had a patient in his 50s who had previously had surgery at a different institution for seizures, and he was completely debilitated by his seizures. Can't do anything for himself, was having a hard time living alone, and doesn't have any family. His church is his family, and his church was thinking that they were going to have to put him in a nursing home because he was no longer sufficiently independent to care for himself. And so he had previously had a craniotomy, and this is a skull that Dr. Sarkar's lab printed for me, showing where his bone had been opened up previously. And so then we used that information to figure out where I could put my SEEG electrode. So I'm going to share screen again here for a second. And this is that working okay? You guys can see it?
Yeah, we can see it, thanks.
Awesome. So this is a 3D view of that. And then these are the electrodes once I put them in. And so using Dr. Sarkar's viewer, I can actually get rid of the skull, look at the brain. I can see where the old brain is missing from his old surgery. And then we were able to isolate and say, hey, his seizures are coming from, and you can see the little gray dots, those are the electrodes that I showed you in the x-ray before. We were able to say, okay, his seizures are coming from this electrode and this electrode. So then I mapped that into a 3D modeling software that's commercially available for the OR and said, all right, this is, electrode 7 to 10 on these two are the ones where his seizures are rising. And we cut that out. And now he's been seizure free and he's back to living on his own and his church family just needs to come in and check on him once a week. So that's how these collaborations can change people's lives in real time between the really, really important work that people like Dr. Sarkar are doing. And that's why we need awesome ideas from people like you to continue to push this field forward.
Thanks so much. I mean, I kind of wish like I had like an hour with each of you because like this is just like so fascinating, and it's just the sort of thing that makes my mind salivate. So, the next speaker is Avi, and what's cool is that what Avi does is very different. And so as we get into the brainstorming session, and it's possible we may run a little bit late, so if just by maybe 10 minutes or so. So if anyone has to leave at 10:30, totally no problem. But if people can stay, then we can maybe do a little bit more of a brainstorming session. And so Avi's a research scientist, and he looks at postural balancing. And one reason why I asked him to talk is because he does like really amazing stuff, and he's a multidisciplinary dreamer, among many other things that he's a master at. So Avi, if you can screen share and do your presentation, that'll be great.
Yeah, I will do that now. Can you see my screen?
I can see it, yeah.
So, hi, I'm Avi, and I work in the same place Vivek works, and it's like a great pleasure to work with this guy. Anybody who knows Vivek knows how cool he is. So I will just give a brief overview of things that I have been involved with. I came into this field trying to do a PhD in physics. So I was not really anywhere related with biology. I didn't want to do anything with biology, but somehow there was this project open where, the American government was thinking about long distance space flight. We don't know when we'll go really long distance. But one of the issues biology faces there is that we lose our bone mass, we lose our muscle mass when zero gravity. So very ancient ideas which are already existing that, okay, the only way we can manage that to not lose our, basically dissolve our body away is to have a kind of, you can see my cursor, right? Yeah, to have a artificial gravity setup where there will be something rotating in space, and that will create this artificial centrifugal forces, and they will help us to kind of mimic gravity. And so that's the background in which NASA gave out money to various labs to figure out, let's on Earth figure out what happens in artificial gravity environment. So that's where I got involved, and I have done things. This is the big motivation, but then I worked and I got an opportunity once to study human balance in parabolic flights. Now it has been privatized, but earlier it was US government was managing it, and I had. I'll show you a few results on that. So next few slides will have a lot of data. We will not go in any detail, just to show you glide through things that one could do in this field. So the first one was, okay, the project that was just put in front of me was, okay, what happens if, well, we have to go, we need this rotating environment to keep our bones safe, but can we hang there? What happens there? So I wanted to figure out what happens to a person if they're just standing in a rotating environment. We do a lot of merry-go-rounds and all that stuff, but to really go into the detail of the science. So yeah, here is one sample project where I put a person in a rotating environment. You can imagine a big room and they're just swaying around. And then what you do is you figure out the trajectories. We'll not go into details, but here is a sample. If you're plotting them with like, you put markers in their body, you track their forces under the feet, and here is a typical example how things change. If you're swaying back and forth, yeah, when there is no rotation, then things become weird. But people learn to adapt and all that. So you can track these trajectories, you can encode all this stuff in more detail, the kinematic variables, how things are moving. Then you can track the dynamic kind of kinetic variables, the forces. You can see, here is just one example. Again, I'm not going to go into details, but like showing that there is some variable like torque, which doesn't care. Here, you know, these are like rotations. When the rotation was given, this is before rotation, after rotation, doesn't really care what you rotate or not. So there are some force variables, doesn't care. Whereas there are other force variables, like here is the weight fraction. And I'm just showing two examples. This is one subject, this is another subject, and they have very idiosyncratic features, like a lot of variability comes in. Well, one person makes like, goes into multiple lines. Then when you stop the rotation here, one person goes back to how things were before rotation, another person does not. They're like, instead of two lines, there's a single line. So then one figures out through studying it, like which dynamic variables don't care, which do care. Then you try to figure out what is really happening. Again, not going into details, but what exactly changes when you do the rotation. You think about it and figure out the differences. Then, because my background was physics, my interest was not to just figure out what's going on, but to try to model. And it turned out in the literature, there was no model. And that's basically what got me my thesis. Otherwise, I couldn't have graduated with a PhD. There was no model which could handle a rotating room. I thought, this is my contribution. That's what I'm going to do. And I thought, oh, this will be a year of work. But it turned out that took me like 3 years to solve this problem. It turns out only when you dig into it that rotating room, just figuring out the model, what we do turns out to be very difficult. And here is, we'll again and again, I'm saying not the details, but I built a model. You build a model, and I'll show you what exactly happens in this very quickly. You figure out, what happens is, I'll just remove this Zoom window from here. Yeah. So the reason it became difficult was, I'll just quickly give you a flavor. When people adapt, what they do is, it's a very unusual kind of adaptation. They develop like these two levels of asymmetries. And what happens is, when people are moving forward versus when they are moving backward, they do different things. Okay, fine, you figured that out. When people are moving forward versus backward, they do different things. Okay, I can handle that. But then they do different things with different legs. If they're doing it with the right leg versus if they do with the left leg, the rules are different. And that's the reason. They're like two layers of asymmetries, and which is not easy to find. You have to find out which particular dynamic variable is doing the job. It turns out it is not in the, it's in the distribution. If you just take the means, you won't see the difference. It's in the distribution of certain dynamic variables where you see the difference. And there are like, they develop asymmetries between their legs, and even when they're moving in different directions. So once we figured that out, okay, then what you do is you start model. You apply this model, and it turns out you end up making these stability diagrams. So you determine, these models have parameters, and you play with it. It takes some time to figure out what these essential parameters will be. They're like, I'll give you some examples, like, the stiffness at the ankle. That can be a parameter, stiffness at an ankle. Then, for example, at what rate, when a person is supposed shifting their weight, at what rate does the weight fraction increase as they move? Suppose this is the two legs, and as they are moving laterally, what rate does the weight fraction change? That is a parameter. Or for example, if they are making corrective torques, what is the, you can somehow, suppose you find out, oh, the corrective torques are proportional to the lateral position of the center of mass, or it is proportional to the velocity. What is the proportionality constant? Things like that. You figure those things out. And then you have to make this stability diagrams, which says, oh, if the parameters are in this black region, this person cannot even stand. if the parameters are and around this region, the person can stand. So you figure out where in the parameter space can a person stand, and of course then you match it with experiments, and we were able to show that as you change the parameters in simulation, what all trajectories come out. That is one exploration you can do. And then this is one thing which one of my most favorite parts, which I got the opportunity to do, is to play with different models. So this is such an interesting paradigm. You can, for example, you can take what happens if I just take a single leg or a symmetric two-leg model, and then I take it just from the literature, I simulate it, and what happens? And you say, well, what trajectories it give? And here is an example I'm giving you. So, so for example, you take a simple symmetric leg model, and then it will do everything in a terrestrial environment fine, no problem. This is going forward, backward, you do right and left, you could get that. If you do circle trajectories, it could do that. These are real trajectories, for example, real data. I can make anything with a symmetric leg model. I can do anything in a normal gravity situation. The moment I put that system in a rotating room, these flowery patterns happen. And that's what makes, again, the system complicated. Symmetric leg models just cannot do the job. This is how they should be, which is almost like they are in a rotating environment. They have adapted. They are almost as good as when they are not rotating, but a symmetric leg model doesn't do. Then you say, okay, let me put one layer of adaptation. You kind of get it. So, oh, look, I put, there are like multiple levels of adaptations that happen. I told you there are two symmetries, the forward versus backward. For example, asymmetry happens. They are not the same. The two legs are not the same. So let me put one of the asymmetries. Well, then you get it while they are rotating, but it screws up when you stop the rotation. And then, okay, then you go to two-leg model, but when you put the full thing, you get the right trajectory. So this is one fun thing you can do. You play with different models. And then, again, in the parameter space, one ends up exploring. This is just for instructive thing, which I got to learn while doing this, that, okay, it's not just enough to find out where a system will fall versus where the system will not fall. There is another kind of gray region where system will not fall, but they will not do the proper trajectories. I had to learn this little hard way. So you have to figure out, so the body tunes its various parameters, its goal is not to just not fall, which is one part of the goal. But another part of the goal is to get the job done, to move the center of mass as the brain dictates it to do. And it turns out those two are different tasks. And then one can figure those things out, like where one can do that job. So these gray areas are where you don't fall, but you don't mimic the trajectory as well. So exploring that was fun. Now I will go to some other tasks. This is another example. Again, going into the same thing, but then the next goal was, okay, that was a person was voluntarily swaying. Maybe I didn't mention that clearly, but earlier task was voluntarily swaying. What if somebody is just standing? For example, if I just keep them standing, what happens? What happens? So it turns out that you are just jiggling around. Your body is just jiggling around like a random walk. And it turns out all the analysis I showed before, all of this till now, everything fails the moment you make somebody stand. None of those analyses give you any difference whether you put a person just standing in a stationary environment or a rotating environment. And it end up, you have to kind of do a modeling. I'm not going to go into details, but there's like, you have to imagine this whole system as like a elastic entity, the body, and then you have to do some stochastic dynamics, and then you can figure that out. So this lesson, it taught me that, okay, in an artificial gravity environment, not every variable will show you what is happening with it. You have to think what exact variables you have to use. So this was another lesson I learned, a completely different set of variables, which showed that, yeah, things change. And when, even quiet stance changes in a rotating environment. Okay, now quickly,
Also,
this was another example.
sorry to interrupt since we're at 10:30.
Okay,
Yeah.
I can stop here. No problem.
Okay, cool. Thank you so much, Avi.
No problem.
I think we all had so many beautiful things to say that we went a little bit over. So I think what I'll do is I'll just do a quick presentation. It is 10:30, so if anyone has to leave, totally no stress. This will just be for the video recording, so we have all of it. And then, you know, if people have time at the end, we could do like a quick Q&A, but totally no stress if people have to leave, because there's been such a beautiful richness of information. So let me share screen over here. And just very quickly, so my name is Vivekanand. I'm a research scientist in the Ashton Graybill Spatial Orientation Lab. And as a very quick overview of like the storyline, imagine that you are an astronaut and you're headed on your way to Mars. You know, you're going to spend months and months in zero G, or if I blindfold you, you won't really know where upright is. And what's really interesting is that then when you have to land upon the surface of Mars, let me just see, there's a chat. Okay, cool, Laura, I'll see you around. Thanks for joining. And oh, I see another chat. Maybe people will have to go. Okay, cool. And Laura said that she's happy to email and talk to anyone. So as you know, astronauts will transition from zero G in outer space, and then they're going to try to land upon the surface of Mars to Mars G. What we know is that they'll become susceptible to spatial disorientation. And spatial disorientation just means you don't have a good sense of where up is. And this is a big problem. Even here on Earth, spatial disorientation in military pilots has a fatality rate of almost 100%. So this is something serious. It's kind of scary. And the question is, well, how do we recreate this on Earth? And what I do is I strap living human beings into this machine over here that is programmed to behave like an inverted pendulum. And all that means is if you do nothing, it just falls over. It's programmed to fall over to one side or the other. And the other thing to notice is that there are crash boundaries. So if you go too far, the machine will stop and automatically reset you. And people are instructed to use the joystick to try to balance themselves at the 0-degree point. Now, the first thing I kind of want you to notice is that people are seated. So in Avi's like really awesome presentation, you saw that usually when people are balancing, well, they're using their legs. And in your legs, you have reflexes, you have the biomechanical properties of your legs, the muscles and the bones and stuff like that. These all aid us to balance. And these are all called our peripheral mechanisms. What's interesting about this paradigm is that because you're seated, you're not really using those peripheral mechanisms. It's really sort of like a window into your central processing. And what that means is that, like, as a collaborative brainstorming link, you know, could we use this window into central processing to look at how does aging affect, you know, balance control and your central processing? What do different patient populations look like? And even, you know, recovery from illness or from surgery. This is just a fanciful idea. Could we sort of see how central processing changes as someone is recovering from these types of things? Now, in the video that I showed you, people were blindfolded, which means that they cannot use their visual system, and they wore noise canceling headsets, so they couldn't use their auditory system. And really, primarily the information that they were getting was from their vestibular system, and a little bit from like their skin as they pushed against that machine. And I'll just really quickly run through this review, but the vestibular system is sort of like your inner sense of balance, and it resides in your inner ear. And it's composed of two pieces. The first are your semicircular canals, which ultimately detect motion during rotations. And really the main thing I want you to take away from this review is that you have these things called the otolith organs in your vestibular system. And one of the things that they detect is tilt from gravitational vertical. The more you tilt away from gravitational vertical, the more those hairs will deflect. And that's why in my first condition, the upright condition over here, even though I'm blindfolded, I still have a pretty good sense of where I am from the balance point, because the balance point's right at gravitational vertical. And the more I tilt, the more those hairs deflect. I can use gravitational information to figure out where I am in space. And in my second condition, what I do is I take people, I put them on the back. I call this the spaceflight analog condition. And you might say, well, what's different about this? Well, what happens is that when you are on your back, and I should also say all the dynamics are the same. If you do nothing, the machine is programmed to fall to the left and right, and use a joystick to try to stabilize yourself around that central balance point. Now, the reason why this is different is if you remember in the upright, you could use gravitational information. The further you went from the balance point, the more those hairs would deflect. But when you're on your back, you're always 90 degrees from gravitational vertical. And as a result, you cannot use gravitational information to figure out how far away you're from the balance point. Really, the only thing that you can use is a sense of how fast are you moving to kind of figure out where you may be in space. And this is why I call it a spaceflight analog condition, because like astronauts, you don't really have a reliable gravitational cue that tells you how far are you from that balance point. Now, I won't go over any of the data, but what I do want to sort of share is that 90% of people in this condition say it's like totally surreal. They have no idea where they are. More than 10% report all sorts of unusual illusions, like they feel like they're completely upside down, even though they're sort of on their back, or they actually are on their back. So that's really, really unusual. And it's kind of an interesting, thought into like, what does the brain do for different people when it's missing a critical sensory cue, such as where, how to use gravitational vertical when balancing. The other interesting thing, and again, I won't really go into the data, is that in this condition, people do something called positional drifting, which is that they get further and further away from the balance point. And if you ask them when they're like 50, 60 degrees away, they're right next to the crash point, like, where do you think you are? These people will say, well, I'm right at the balance point. So that's kind of unusual. They're 50, 60 degrees away. They're right about to hit the crash boundary, and yet they perceive as if they're at the balance point. So really the next sort of collaborative ideas are, can we use this condition to sort of simulate a vestibular illness or other sort of patient populations? The other presentations sort of talked about the idea of anxiety, and there is some sort of evidence that I see in my data that those people who are prone to anxiety do very poorly in this spaceflight condition. And so some of the collaborative ideas may be to study how do people deal when they're disoriented, or what do people do when the world doesn't make sense or they can't trust their senses. The other things are sort of like, NASA's interested in how is surgery affected in zero-G. And then, Korek's presentation was on VR, and one idea is sort of like, our lab studies motion sickness. And so some of the questions that Korek was asking, there are experts, I think I saw Joel in the audience, and they can actually talk extensively about the motion sickness research that we do in the lab. Very quickly, the other collaborative idea is that could there be mathematical similarities that I see in my data as a person approaches a crash that may also be similar in other crashes? For example, oscillating systems. The brain is an oscillating system, and could potentially a seizure be something similar to a crash? Now, this is, again, a fanciful thought. I'm just putting it out there for brainstorming. So the other things that we're doing, and one of the presentations talked about machine learning and deep learning, in collaboration with the computer science professor and Yong Lin, who I think is on the presentation, or like in this audience. We're using deep learning to be able to predict, before a crash, like predict a crash before it happens. And again, some of the collaborative links here is that could we use deep learning to be able to, predict the approach into seizures or help in the visualization of disease? I'm sure there are deep learning papers on both of these things. But one interesting thing may be that does training a deep learning architecture on sort of balances and crashes in any way help in these two different things that we talked about? Finally, I'm looking into human augmentation, and on the back, there's a missing gravitational cue. And Avi talked a little bit about some of that stuff too. And one idea that different people are trying is trying to replace that missing gravitational cue with vibrations on the body. And the other thing, these are two high school students, and they've developed this cool drone, again, as a form of human augmentation that activates based on body sway. And the collaborative links here is that, can we use human augmentation, for example, in Korek's presentation, to enhance medical visualization? What if you can visualize, through this, VR experience, something in the brain, but then on your body, you're feeling vibrations that's giving you extra information? Or during surgery, if you get vibrations on your body, that gives you some indication of, I don't know, some important qualities of the brain, does that enhance your performance? So these are also things that we can talk about. Finally, our collaborative link, this is all part of sort of like an educational outreach thing. And so we're going to package this together in a video and do a sort of brainstorming session. So now what we're entering into, and we are 10 minutes overdue, but for whomever, and no stress, if you have to leave, you can leave. But if anyone's around and anyone wants to ask questions or have a discussion, I'm more than happy to stay on, and anyone who wants to. And so we can ask questions and brainstorm and explore different spaces. All right, and let me see if I can enable everyone to now, you can chat now and everyone can unmute themselves. So cool, any questions that people have, any comments that they have on connections with what we have here? And I think you can unmute yourself.
So I have a question for Korak and Laura, if they are there.
But Laura unfortunately left.
Left over. That's
Korak is still here, yeah.
Let's me do the core. So you showed this 3D making of the whole thing. Now, why make a real physical 3D versus? I'm just make a real physical 3D versus in a computer. Just manage to see things in 3D, where in a software, through a software effect, we see 3D. Does it matter? Or both are same, or it really matters to get it into a really 3D physical? Are you doing both, or one is better than the other?
Yeah, it's a great and insightful question. And what we're learning is the most adopted and the entree into other capabilities is basically a 2D viewer on a phone, tablet, the way that Dr. Kahn demonstrated the electrodes. So that is basically our biggest and most commonly used deliverable. And we use it as a design tool as well to confirm, if necessary, if we need to create further downstream models, particularly 3D printed models, and just to preserve our materials and printer time. And there definitely is a subset of use cases where the 3D print and that haptic feedback is really important. You know, in a spine or orthopedic case, if you wanted to see how you were going to put a screw in, yeah, right now our applications don't have those kinds of capability. Our XR, we can't like drop in a digital screw and let you manipulate that. We don't have that capacity. But you can take a 3D printed model and take a, you know, a generic screw that's, you know, not sterile, and start manipulating it. And so there's definitely a role from an innovation perspective. I started with 3D printing honestly just as a nerd fascination. If going back, if I would have done it kind of the way you were intuiting, is let's start with simple 2D, you know, a 3D projection on a 2D plane, and see where it goes from there. Yeah, so.
Okay. Thank you.
Joel,
I actually, so, is it
oh,
okay?
sorry, go ahead, Mike. Sorry, I'm sorry, go ahead, Mike.
So my name's Mike. Thank you so much for presenting this and for everybody who talked. These are really fascinating topics. I have worked with Dr. Sarkar before. I'm an augmented and virtual reality developer with a particular interest in neurology as well. And one thing, just sort of piggybacking on what Dr. Sarkar said, one thing that I've noticed about the 3D printed models that he's presented to some of the surgeons that we've worked with before is the ability to sort of rotate the models in their hand. And this actually informed a lot of VR design. The idea that there's some sort of proprioceptive feedback that allows you to construct the three-dimensionality of the object when you're sort of rotating it and holding it in front of you is something that's sort of been in my head as I've been designing for VR. And I'd love to hear thoughts about people who understand more deeply our proprioceptive systems, how they tie into our visual systems, and sort of create models in our brain. There seems to be a lot there that I'd be interested in exploring.
Avi or Joel, do you guys have an answer? Because that's a beautiful question. I could try to answer, but I feel maybe if either of you have.
I don't have an answer for that, but I can imagine. Yes, I can imagine. I mean, I'm imagining in surgery. This is news to me that touching something gives you more cues in 3D. Gives you more cues to how to do get to your goal in surgery than just visualizing it. This is new news to me, and like I'm still appreciating it.
Joel, any comments or should I?
No, I don't really have any comments.
Yeah, I think it's a fascinating question. You know, like I know with some of the research that I do, again, where like people are disoriented, where people don't have a good sense of what's going on, and and I feel like I've read literature on like laparoscopy and stuff like that, where you have a camera going through the body, and sometimes you get disoriented, I don't know, within the intestines or whatever it is. What can you do to enhance performance? And certainly, like with like the human neuroscience or whatever you want to say, you have multiple layers of sensory information that are supposed to sort of converge together, so you have a very good sense of where you are. In my research, if you take one of those things away, you can make critical human mistakes. So having sort of like a proprioceptive element on top of like a haptic element on top of a visual element, certainly I think would reduce like the rates of like mistakes that may happen, and also allow you to I feel like there's literature that when you have multiple sensory inputs that are coming together, converging, and you don't have sensory conflict, that it actually reduces your reaction time so that you're more effective at what you're doing. And when you only have, the problem though, I should say, which would be actually interesting, is that once you're immersed in like a VR environment, to a certain extent, cognitively, you know that this is kind of like not real, this is different, right? And if you then introduce a little bit of sensory conflict, where you're like, what I'm seeing in VR, just because of the way it's moving, or maybe the way that it's lagging, is a little bit different than what I'm feeling with my proprioceptive, senses. That then may lead to bigger problems. And I'm just saying this as like a thought experiment more than I'm not sure if I've specifically read it, but that's part of what my research is as well. And in the lab, we've actually done VR, AR stuff where you get sensory conflict coming in, and it leads to a whole bunch of different mess. And so that's also part of like the exploration. Like you can augment the human, but these things can actually maybe lead to worsening performance in certain situations. And I feel like if I think more, I could give you like a better answer. So if you're ever up for like a follow-up, I can actually do a little bit of reading and give you like a better thought.
What Vivek said, I have one example, but not from the academic field, where and I just recollected it just last minute, that where a person, me, relied more on my proprioceptive and cutaneous than anything visual, of course, no sound. And it was while in a field of blackberry plants. Blackberry plants have these thorns in them, really prickly thorns. And this is a dense field. And once I see that there's a blackberry route there, visually, because it's so dense, vision does not help you. So what helped me is that you poke your hand in and you feel your way from thorns. Oh, this is pricking, not here, not here, not here. And now your posture has gone all the weird directions. So you have to balance yourself. You're feeling where my hand is going. I'm cutaneously sensing where the thorns are. And it was amazing. I succeeded. I succeeded multiple times. I didn't know how I am doing it, but I was doing it. And I did better closing my eyes. You target location, then you just close your eyes and you just feel your way through it and get the blackberries and get it out.
That is really fascinating. I hadn't thought of that. And actually, another comment that Dr. Sarkar made is about motion sickness inside of VR, which is a particular pet project of mine. How do you move people in a virtual space without making them sick? And real quick, maybe people already know this, but one of the main issues is a mismatch between your visual and vestibular system. It's very akin to motion sickness on the car and the sea, except inversed. So instead, you're getting all these visual cues of motion, but your vestibular system is telling you that you're not. And one way that I've seen really helps is if you do something like having the person swing their arms, or if they have to move through space in order to locomote, so sort of like grabbing and moving through their environment, it seems like you can actually use the proprioceptive system and the visual system to override the lack of vestibular input. Again, this is just sort of like armchair sort of guessing as to what's going on and why people who are really uncomfortable in VR seem to feel comfortable as long as they're moving their body to navigate throughout the environment. And so if anyone has done any research or would like to follow up on that, I'd also be super interested to have those conversations as well.
Joel's a master of motion. Joel, do you want to anything about your research in motion sickness?
Yeah, well, that that's a very interesting observation, and I've never seen any research on that. And I've looked at a lot of motion sickness research literature. It's a very interesting observation, and I just wonder if it allows the system to to put so much noise in there that it doesn't no longer that you don't have, since you have so much vestibular noise, the fact that it doesn't match up doesn't bother the subject anymore. It's really interesting. I'll try and steal your idea someday, I think. But I was just thinking another instance. We used to do research on the Vomit Comet, parabolic flight, and there, you're moving around in 2G and 0G, so you really get messed up. And then after you get off that airplane, if you walk on the surface, you can, when you're moving up and down as you walk, there's two ways for your perceptual system to interpret that. One is that you're walking on not a steady, non-accelerating surface, and your body is moving up and down. But you could also interpret that as that you're walking straight and the surface is moving up and down. Well, we never do that. But once you get off that airplane, you start walking, you feel the surface moving. Like it's deadly to walk upstairs. Every time I press down on a step, I feel the step crushing down. And when I get off that airplane, I never go up on a ladder for a week or so afterwards, because those after effects are long lasting. But the thing I remember the most, you normally readapt to that. And this is how it relates to what you just said. But periodically, I had to drive the equipment back from Houston on the truck. And I'm in this motion environment for hours and hours. And then I get out of the truck and I start walking on the ground, and I have not readapted, all right, because I've had all this motion stimulation from the truck. So I start walking on the ground and I feel the ground moving again. Whereas if I had been actually walking on the solid surface of the earth, I would have completely readapted in that period of time. So
I think it's really fascinating stuff. And, intersections in like the research that, we do in this lab and what you're talking about is first like looking at individual differences and like who's most susceptible to like, visual stimulation. So like, for example, in some of the research that we did in the lab, this is preliminary research, we found that some people are more vestibular oriented and will get, like motion sick maybe more from vestibular stimulation than visual, whereas others are like more visual. And then of course you have like a bunch that are mixed. So looking at like individual different, and none of this is known, like individual differences and who's susceptible to VR-based sort of like stimulation, I think would be an interesting, intersection. There's also a whole bunch of things on like adaptation or sensitization. So if you're like, if you have prolonged exposure, and Joel is like a great, if I can use the word torturer, of making people get close to vomiting, which I've experienced, on a few occasions. It's interesting, like, can you get to the person to the point where they're adapted, or do they get more sensitized and now they almost have like an allergic reaction to any small change? Other things that the lab has done is looked at sleep and its effect on like motion sickness and VR. And then, I'll put out something a little bit crazier too, that like, different groups, I think NASA's looking at it a little bit and stuff like that, but it's a little bit like out there and how legit it is. So, you can do like, vestibular stimulation while you have a VR on. And, there are different things you can do. So the first thing, like as Joel was saying, is you can sort of dump a little bit of noise in there and see what happens. You can do things like stochastic resonance, which is related to noise, but it's within like a particular range. Or you can try to like be a little bit more delicate, and the movement that you see in the VR environment, you try to get some sort of stimulation that follows that pattern. But a lot of these stimulations are just like a rough hammer. You don't really know exactly what you're hitting. But these are potential like collaborative research ideas that we could explore.
Yeah, I want to make two other comments about motion sickness. First of all, it's one of the most variable parameters of human beings. They vary. Motion sickness susceptibility varies over a range of 10,000 to 1, at least, across individuals. It's huge variability. And then cyber sickness is really a big deal these days, because so much of it is virtual reality is going into so much in every field. And in fact, and we are collaborating with researchers at the University of Iowa who I'm meeting this afternoon with them actually. who specialize in just in looking at motion sickness in virtual reality situations.
Yeah. And I think, I think we can, at 11, we can stop just so that it doesn't go too forward. But the other two things, again, like, we do have Younglin who does deep learning. So if there are any questions, maybe, she can explore some of that. And the other aspect was just like human augmentation and, do like feeling vibrations or other types of augmentation assist in medical imaging or in surgery. And then Laura, I think, the other thing, when I go to these NASA conferences that they're looking at is sort of like, what does surgery in zero G look like? And how is it different? And like, there's a whole universe of like interesting ideas. And some of the things that they are looking at is like minimally invasive things, because like that's a little bit maybe, I don't know, more feasible to do in like a crammed zero G environment. So those could also be like collaborative explorations that we can explore. Yeah. Any other questions or thoughts? Oh, Punya, yeah.
Yeah, I just had a quick question. So I was working on this project for a class on machine learning, and it was pretty simple classification and all that, but it was relating to brain cancer and brain tumors. So a quick question. So I guess, yeah, what are the differences between just taking like, doing a PCR or some sort of test on a person to get their gene expression levels versus taking an MRI and having, a doctor analyze that or a neurologist analyze that versus having, a bunch of images and using machine learning to analyze, what sort of issues are coming up in the brain scan?
So if I understand correctly, your question revolves around the diagnostics and the utility and the role of varying diagnostics. So it really varies from disease to disease. And, I do a lot of traumatic brain injury. Concussion is almost completely really a clinical diagnosis. There are imaging and biosurrogates, blood surrogates you can get, but in general, I don't use them in practice. Versus on the other end of the spectrum, if you have COVID, really, the definitive diagnosis is a seroserology or a blood test. So it depends, and in general, multiple modalities can help refine. It's about being sustainable and optimally using the diagnostics to get the answer you need with the resource, with the most efficient utilization of resources, and minimizing obviously the risk to the patient.
Sorry, there was some background noise, so I didn't hear your whole question, but was it getting at how machine learning might be able to help optimize like diagnosis of brain tumors based on imaging modalities?
Or yeah, kind of the differences in between doing something like gathering gene expression levels for a certain subject versus, having an MRI scan. And then, if you get that scan, having either a doctor look at it or taking multiple images and then using, machine learning to identify what the issue is in the brain. So yeah, what are the advantages and disadvantages, I guess, and which one is better?
Yeah, so I think that, in current clinical practice, when it comes to brain tumors, which is not the primary area of my specialization, but certainly something that I deal with a fair bit, it's definitely a tissue diagnosis. So that would be looking at genes, looking at the way things are expressed on the slide and looking at specific stains to see, hey, we are going to treat this glioblastoma, which is the Ted Kennedy brain tumor, based off of what the molecular signature is. Does it have an IDH wild type or is it IDH mutated? And that indicates whether it's a de novo tumor or may have mutated from a lower grade glioma earlier in life that could have even gone unnoticed. And also, does it have hypermethylation of MGMT, which is a gene promoter sequence that correlates with how likely the tumor is to respond to an alkylated chemotherapy or not. And so I think that's still from the brain tumor side, which again, is not my primary specialization, but from what I know of it, that's still sort of our gold standard at this point in time. It's really looking at the genetics. But what can be helpful And again, I'm reading into your question maybe, and I hope I'm not taking it in the wrong direction, but if with where I see machine learning fitting in as a useful correlate is knowing ahead of time before we take the patient to the operating room, do we have a higher index of suspicion that this is a glioblastoma versus maybe a meningioma or lymphoma? Because the way we approach those surgically can be different. So yes, the pathway to get to that tissue is the same. But if I know that a patient, say, has a lymphoma, which responds very well to chemotherapy and radiation compared to a glioblastoma, where I know that taking out as many of the abnormal cells as possible is going to correlate with a better survival, well, those two things will change then how much tissue I take out. And so it may not make that much of a difference if it's in an area like, say, the inferior frontal lobe, where I know I can take out the tissue and it's not going to make that much difference in the patient's quality of life. But let's say it's in an area that is very important or is adjacent to an area that's very important. So if we're going in the further back part of the frontal lobe, that's an area that's not necessarily the direct primary motor cortex, but it's an area that helps us to coordinate movements. And so if I know and initiate movement. So I know that if I damage that area, most patients will be able to recover in say 3 to 4 months. But if a patient's only going to live for another 6 months, is it worth it? And that's where I think machine learning and anticipating ahead of time can make a big difference in patients' outcomes and quality of life and how we think about things.
Cool, thanks so much. And we are at 11 o'clock, so much appreciation for everyone. And Laura, thank you so much. And Avi for presenting. And I'll send everyone information about the video and stuff. But thank you. Bye.